Thank you, Salma. Now I would like to call Dr. Ussama Munir. He will present intra-aortic balloon pump.
Assalamu alaikum. My name is Dr. Ussama Munir. I am a consultant cardiologist in Bahawalpur Cardiac Center. So the topic I am going to present is basics of intra-aortic balloon pump. So first of all, the introduction. Intra-aortic balloon pump was initially used for the treatment of cardiogenic shock, initially used for the temporary support device, and largely being used in Pakistan for the as a main mechanical circulatory device that is being available in Pakistan. Initially, it was started by Kantowitz in 1952 and then by Harkin in 1958. Initial clinical application was successful, and then first balloon was used as a pre-folding balloon. That was in 1985. So these are the indications of intra-aortic balloon pump: cardiogenic shock, pre-shock state, septic shock, acute MI complicated by VSR, acute MR, unstable angina, cardiac contusions, even high-risk patients with undergoing PCI, prophylactic support, intractable ventricular arrhythmias, and bridging to mechanical other transplantations, and post-surgical myocardial dysfunction. So the contraindication of intra-aortic balloon pump is aortic valve insufficiency, that is mostly aortic regurgitation, dissectic aortic aneurysms. Relative contraindication, these includes the end-stage cardiomyopathies, patient cannot be transferred for liver transplantation, severe atherosclerosis, abdominal aortic aneurysms, blood disorders, and end-stage terminal disease. What are the complications of this intra-aortic balloon pump? Complication mainly associated with excess site complications like vascular limb ischemia, vascular lacerations, aortic dissection, spinal cord, peripheral thrombotic embolization, false aneurysm. Then the balloon-related complications, these may be migration of balloon, balloon perforation, thrombocytopenia, anemia, and infection. So the component of intra-aortic balloon pump, these include a console that have multiple ports in it, the ECG, aortic arterial blood pressure waveforms, balloon volume monitoring, triggering, adjustment, battery, and gas reserves. So this is the console that is showing the diagram here. This is a monitor that shows the ECG as well as the arterial pressure waveform, and the back of the console that shows the multiple triggers that are used being there. So the triggers that use for intra-aortic balloon pump, these may be ECG triggers, arterial waveform triggers, internal triggers, and pacer triggers. The important thing is that when you have the arterial pressure tracing, it should be good enough. The aortic notch, the diacortic notch should be clearly visible on that waveform. So then your balloon pump will work great. If your pressure tracing is not good, probably there may be some malfunctioning of the intra-aortic balloon pump. How it works, this is simple, a flexible tube that is passed through the femoral artery. Mostly in our setups, when we used to do intra-aortic balloon pump, we initially pass a 4-French sheath and just do the check injection of the femoral artery, whether we are in the common femoral or not. So if we are in the common femoral artery, then we proceed further for the balloon pump. If we are not, then we change the access site. So this is just a flexible catheter of 10 to 15 centimeter balloon at the end. The tip is positioned just 2 centimeter below the subclavian artery and above the venals. Catheter attached to the pressurized flush system. Catheter should be air-free completely, and helium is used in this balloon pump. So position can be confirmed with the help of the X-ray, fluoroscopy, transesophageal. As we are using this mostly in the cath lab, so the most important part to confirm the position is under the floor. So this is just a diagram that is showing the relationship between the left subclavian artery and the tip of the balloon pump. So it should be at least 1 to 2 centimeters distal to the left subclavian artery. Proper positioning is important in this to get the maximum benefit. And avoiding the venal arteries just below to avoid renal ischemia. So the gas that is used in intra-aortic balloon pump is the helium. That is the low density means, less turbulent, can be shifted easily. It can inflate and deflate very quickly. In case of rupture, it can reabsorb. There is less risk of air emboli. So the sizing of balloon is being done on the basis of height of the patient. If the height is more than 6 feet, we use 50 centimeters. Routinely in our setup, we use 40 centimeter across all height groups. Except for the patient that is very low height, less than 5 or 5 to 5.4 inch, then we use the 34 inch. Otherwise, the routine use was 40 centimeter balloon that was commonly available. So inflation and deflation. Inflation occurs just as the diastole begins. You compare the inflation with the help of dichotic notch. at the time where aortic valve closes. So when the balloon inflated, it almost blocked the 80 to 95% of the aorta. Complete occlusion is avoidable. It may damage the wall of the aorta as well as RBC and other platelet dysfunctions. So deflation occurs at the end of diastole that causes loss of pressure, reducing the amount of work required. So this is the diagram that is showing the balloon pump in deflate state and inflate state. So it is inflated in diastole and deflated in systole. So there is negative pressures in the aorta that leads to unloading of LV and improved cardiovascular work. So the hemodynamic parameters that are helpful with the help of this intra-aortic balloon pump, the systolic pressure decreases, but there is an augmentation of the diastolic pressure. So this is the normal waveform that shows the dichotic notch. With the help of intra-aortic balloon pump, you can see this diastolic pressure augmented further with the help of this balloon pump. So the mean aortic pressure that increases, left ventricle afterload decrease, mean pulmonary wedge pressure decreases, cardiac output increases, ejection fraction may increase, heart rate is decreased with the help of intra-aortic balloon pump. The major role of intra-aortic balloon pump after the cath lab in the cardiac CCU or in the ICUs is the nursing care. It should be done routinely. Cardiovascular and hemodynamic assessment should be done whether pressure waveform is available or not. Positioning is important, observation of catheter and insertion sites. Vitals should be monitored regularly. Peripheral signs should be done. In our setups, we used to do this ultrasound for the posterior tibial artery and dorsalis pedis artery just to confirm whether balloon is occluding the vessel or not. Other insertion site, hematoma, hemoglobin, platelet count, these should be done regularly. Neurological status is important. Then confirm the timing, ratio, and triggers of IABP. Observe for bleeding at the cannulation sites. Then arterial pressure, temperature, respiratory rate, and oxygen saturation should be done. The weaning should be done as slow as possible. Initially, the ratio should be decreased 1 to 6 hourly. Initially, augmentation is done in 1:1 ratio. Then it should be decreased every 6 hourly. And once it is at 1:3 ratio, then monitor the hemodynamics for 30 minutes, then stand by, and then remove the balloon. Before removing the balloon, try to negative as much as possible because removing the balloon through the sheath is very difficult sometimes. The balloon may stuck there. So it is important that you should have an important negative suction at the point. Use 50 cc syringe and then do a negative suction while pulling out the balloon pump. And support weaning is important. Vitals should be monitored, and after monitoring of the vitals and other hemodynamics, then should be wean off. Immediately weaning off the balloon pump may not help the patient. So initially, if patient's hemodynamics are maintained at steady time, then it should be monitored further, and then balloon should be wean off. The parameters that should be used, that is urine volume, blood pressure, heart rate, and total bilirubin, that should be monitored. So this is all about the basics of IABP. I thank you all for giving me the opportunity to present today. Thank you so much.